EGFR mutations are seen in about 15 to 35% of patients with lung adenocarcinoma. And for these patients, EGFR inhibition is the standard treatment. Erlotinib, gefitinib, and afatinib are the three currently available agents. And they all are effective, but ultimately patients develop resistance. And if you look at the mechanism of resistance, nearly half of these patients will develop resistance through the T790M pathway. Osimertinib, which is the drug we studied in FLAURA, is a third-generation EGFR inhibitor. It blocks the common sensitizing EGFR mutations and also the T790M mutation. So our hypothesis was, if you give osimertinib as first-line therapy, can you shut off the emergence of a main resistance pathway and thereby improve outcomes for patients? We had seen some promising preclinical observations, and we had also done a small expansion cohort from a phase 1 study of osimertinib in the frontline setting that showed a promising response rate of 77% and a median PFS of 20.5 months. So based on all of these lines of evidence, we proceeded to conduct the FLAURA trial. So the FLAURA study randomized 556 patients to treatment with osimertinib or standard of care, and standard of care included gefitinib or erlotinib. The primary endpoint was median progression-free survival. We were delighted to find that patients treated with osimertinib had a statistically and clinically significant superiority in median PFS. It improved from 10.2 months in the control group to 18.9 months in the osimertinib group, and this was a 54% reduction in the risk of progression or death for patients treated with osimertinib. The p-value was highly significant, hazard ratio was 0.46. The second efficacy parameter we looked at was the duration of response, and that was almost twofold higher for patients treated with osimertinib, 8.5 months for the control group and 17.2 months for patients treated with osimertinib. And finally, when we look at the survival results, which are relatively immature at 25% of the events at this time, we see a promising hazard ratio of 0.63 favoring osimertinib. So across all efficacy parameters, we find that osimertinib is far better than the standard treatment options that are presently used. We looked at various patient baseline characteristics and see how they correlated with outcome. Whether you had a patient with exon 19 mutation versus exon 21, were there any differences? The answer is no. The hazard ratios were comparable. We looked at patients who were Asian and non-Asian, and the hazard ratios again looked comparable between the two. Another subgroup we were interested in is those patients with history of brain metastases. There were about 120 patients who came into the trial having had documented brain mets. And when you look at the outcomes based on whether a patient had brain mets or not, in both groups osimertinib was better, and the hazard ratio was comparable at 0.47 and 0.46 for patients with and without brain metastases. Furthermore, progression in the brain was much less common with osimertinib compared to standard of care. So in all the key subsets that we saw, osimertinib appeared to provide robust benefits. Osimertinib is a mutation-specific inhibitor and has a high selectivity to the mutant receptor compared to the wild-type receptor. In this study, patients were exposed to osimertinib for a lot longer time, at a median of 16 months, compared to 11 months for patients in the control group. So the likelihood of accruing toxicities are higher, and despite that, when you look at grade 3 events, it was lower for patients treated with osimertinib. If you look at treatment discontinuations due to toxicity, that was lower with osimertinib. Skin toxicity and liver enzyme toxicities were lower with osimertinib. The rest of the toxicities were similar between the two groups of the trial. So overall, I would say the safety profile is at least similar, if not slightly more favorable with osimertinib as standard of care. We're beginning to understand the mechanisms of resistance to osimertinib. One event that's been reported is the C797S mutation that happens in a small subset of patients exposed to osimertinib. There are also other growth factor pathways that are activated. We just recently published our first-line cohort experience from the phase 1 study in the Journal of Clinical Oncology just last week, and that has more information on resistance mechanisms as well. So we're still in early days of understanding mechanisms of resistance. What we're seeing in patients treated with osimertinib is they have slightly different mechanisms of resistance. And the good news is it does not appear that these patients develop T790 at all. So you are completely shutting off that pathway and patients find other ways to develop resistance. We are reassured by doing some subset analysis that this does not result in a more aggressive form of resistance. In fact, the benefits of osimertinib go quite consistently, and patients who progress on osimertinib get something else also fare better compared to patients in the control arm. So overall, we feel comfortable that while we're shifting the biology of the disease, we're not pushing it towards a more aggressive phenotype. The FLAURA study established superiority for osimertinib compared to standard of care in PFS, duration of response, and a favorable overall survival trend. And when you take that on top of a favorable efficacy safety profile, we feel that it is now a standard option for frontline treatment of EGFR mutation positive disease. We're always looking for what's better to improve the outcomes for our patients. Erlotinib and gefitinib have been very valuable in the management of lung cancer. We see the next step forward as osimertinib, and we're already beginning to think about what's beyond osimertinib.
Thank you very much for your time. That's great.
Thank you.